Welcome back, ladies and gentlemen. Next up, we have our second guest lecture on Sleep Year in Review, presented by Professor Jason Ellis, who is a professor in psychology at Northumbria University. He's also the director of the Northumbria Centre for Sleep Research in the UK.
Welcome everyone to the invited lecture, Sleep a Year in Review. These are my conflicts of interest. If anyone would like to discuss any of those, please feel free to contact me. So before we start, I'm just going to say, I'm probably not going to talk about COVID. I think there's quite a lot of information out there. And so what we're going to focus on today is some of the innovations that we've seen around sleep management over the last year. And we're going to start with updates in the management of CPAP adherence. And this is quite a big issue, as we all know. This is a really nice paper by Bertrand and colleagues from the University of Laval. And what they're really attempting to do in this paper is try to understand the role of psychological and psychosocial interventions. So what we do know is that if we add psychosocial interventions, we can impact on levels of CPAP adherence. So what was the main method and the aims? Really, they had three main aims in this piece of work. And they were going to try to determine what sorts of psychosocial interventions exist in the context of CPAP, how and why do psychosocial interventions increase adherence. The way that they approach this is a systematic literature review. They looked at 6 main databases and they found 14 main studies that were included in the final review. So what were the findings? What sorts of psychosocial interventions were there out there? I think one of the main findings that we've got is actually 13 out of the 14 studies did demonstrate improvements in CPAP adherence. That's great news because it is a challenge to most of us. But what were the interventions that were outlined in this review? 6 focused on motivational interviewing, and that's a process by which we set targets and we get the patient themselves to set their targets in relation to where they are. 3 of the interventions were CBT based, and the other 5 were a mixture of different styles such as coaching and exposure therapy during the daytime, or indeed relaxation techniques. Overall, irrespective, however, of the different intervention, they all tended to demonstrate some improvement in levels of CPAP adherence. When the authors looked more specifically at what were the factors that influenced the effectiveness of these interventions, they came up with 5 main themes. The first was called time-related. And what this really demonstrated that the first week after giving CPAP is vital if you're going to introduce a psychosocial intervention for CPAP adherence. They actually discussed that if you could do it prior to giving CPAP adherence, it would be even better. But we know that there are generally a lot of logistical issues around that. But within the first week, if we were to have these interventions, they become much more effective. What about adaptability? Making it meaningful for the patient. And so you've got all of the different types of intervention, but what is it that the patient actually wants or needs? What are the improvements from CPAP that we would be tangibly telling someone to make it meaningful for them? The third characteristic is patient characteristics. And in this instance, it was looking at those people who had comorbidities. And one of the challenges is that we do tend to see less adherence in people who have a comorbidity. And so we have to be mindful of that and mindful of the benefits, not only to that individual which we talked about a second ago, but also making them meaningful around their other chronic condition. The nature of the intervention itself was also demonstrated to increase the efficacy. Short interventions, generally 1 or 2 sessions, which generally would be working around an hour to 2 hours, really did demonstrate that allowance in terms of CPAP adherence. And so it's a great thing, really, in the sense that it's not having to put too much effort into that in terms of how much time we tend to put forward. Finally, they found that setting intervention targets was also very helpful in terms of increasing CPAP adherence, most notably increasing self-efficacy, the belief that someone can do this themselves. So this really does give us a great indication of some of the ways that we can increase CPAP adherence. What does it mean to our specialists? Well, if you want to increase accessibility and acceptability for our CPAP, then adding in psychosocial interventions that are meaningful, that are short, and that are very timely will help us with CPAP adherence. The other area that we'll talk about in terms of CPAP adherence is partners. And we've known for a very long time that actually, in many instances, it's the partner that tends to initiate the patient's journey through to CPAP. They're the ones that tend to be reporting it to the partner, and therefore it then translates into the healthcare service. So what is the role of partners in our understanding of CPAP and our understanding of CPAP adherence? So what they wanted to do in this particular paper is look at the impact of the partner. Again, very similar to the last study, they did a systematic literature review. They had 4 databases, and they actually had 21 studies included in the final review. 15 of those were qualitative, 5 were quantitative, and 1 was a mixed methodology. So quite a nice spread in terms of the different methods that they found. What were their main findings? In essence, they can talk about partner involvement and engagement, but actually we have to start seeing this on a much broader scale, right the way through from a patient's own autonomy, right the way through to substitution. Now, what do we mean by that? When we have the patient autonomy, the partner doesn't have much involvement in the individual's diagnosis or indeed in their adherence to their CPAP. It's almost as if it's left to them, so they have to deal with everything themselves. Right on the other side is substitution, and this is where a partner becomes overly engaged with their partner's CPAP, checking, monitoring, offering advice. What they found actually was that there was this middle ground, which appears to be the most beneficial in terms of partners and their impact on adherence. There is a shared management approach. And what we mean by the shared management approach is that it's taking more of an approach of helping the partner understand their CPAP, helping the partner manage the CPAP, and helping out in other ways, but not taking over responsibility for the individual's adherence. The other main finding from this piece of work was that they found that actually partner engagement is vital for long-term adherence, especially in the first month. So it's almost as if we should get the partners engaged at the time that we're giving out CPAP in order to help people within that first month start tractioning towards a long-term adherence. Now, I talked in the previous study about what makes something meaningful is quite important in terms of adherence. This is where we found that there was some elements around CPAP adherence related to the partners. And so, again, we might want to think about that adaptability, not just in the partner, but what's it actually conferring for the wider individual's life, such as their family. What they found from largely the qualitative research was that there were four main domains under which a partner would be able to influence CPAP adherence, and where CPAP adherence tends to show that adaptability. The first is increased quality of life, making that meaningful, that if somebody is adherent, it impacts on the quality of life of the family, the wider social unit. Increases in sexual functioning and relationship status, mood, and finally, of course, as we might expect, increased sleep quality and daytime functioning. So really the take-home message here is, if you do want to bring partners into understanding CPAP and CPAP adherence, these are the four elements that could be discussed, the improvements, which would then relate to that shared management approach. So what does it actually mean overall in terms of our specialisms? We really do need to understand that partners can influence somebody's CPAP adherence, both negatively and positively, or even neutrally. And it's a term that I tend to use quite a lot. It's alliance versus reliance. If you've got that reliance on the individual to make sure their partner has that CPAP adherence, it can influence the CPAP adherence, but it also can have a knock-on effect on relationship status. So we do need to put people more into that shared model of alliance around CPAP adherence. Okay, what about assessment methods? And we'll talk about one study here, which I found very interesting. And for full disclosure, I am an author on this particular study, but it asks a really interesting question. When we ask people subjectively about their sleep, we tend to use the same questions, or we use the same psychometrics, such as the Insomnia Severity Index or the Stop Bang. And the question really comes down to, are they meaningful in the same way? So, in other words, the judgments around sleep, are they actually meaningful for people across different places and spaces? So this is some data that was from the World Health Organization, and it's about 207,000 people across 68 different countries. So what was happening in this context? One of the things that we looked at in this instance was fatigue. So sleep and fatigue. At what point does somebody suggest that they have a problem with their sleep or a problem with their fatigue? And is this the same fatigue or sleepiness that you would see in one country, in one gender, compared to another country or another gender? So the main aim really was, are these judgments relating to poor sleep systematic across people, places, and spaces? As I said, we used data from the World Health Organization, which had something called weighted vignettes. In other words, what was given to the patient was a vignette around sleepiness, where they had different scenarios of how much impact that the sleep problem was having on that individual's life. And the individual themselves, the participant, rated that against how much they thought that person had a problem. And that gives us a weighted judgment about their understanding of when does sleep actually become an issue. As I said, it was over 207,000 people across 68 different countries. Unfortunately, we had to exclude Turkey because there were some issues around the data. What were the main findings? Actually, believe it or not, sleep quality judgments tend to be comparable across people and places. So irrespective of where people are in the world, it doesn't tend to impact on different judgments around sleep quality. The one area that we did determine that there were differences in terms of judgments around sleep quality is related to educational status. In this instance, when we had people of a lower socioeconomic status, they tended to identify sleep quality judgments very similarly. However, people of a higher socioeconomic status, they tended to see minor sleep problems as more problematic, and they tended to ignore more severe sleep problems. So it is something that we need to be mindful if we're looking at cross populations, different people, places, and spaces, is that education does tend to have an influence on our judgments. We will come on to cognitive behavioral therapy for insomnia. And I think this is a really interesting study. And the reason that I want to talk about this study is because it's giving us our very, very good look at long-term outcomes from CBTI in terms of its impact on our patients. So the aim in this context was to see the short and the long-term impact on CBTI on symptom severity and insomnia diagnoses. What they did in this instance was a systematic review and a meta-analysis using two databases. In essence, they had 133 patients with insomnia and a 6-week guided bibliotherapeutic CBTI. What they found from this is that actually, if we start looking at the ISI, the Insomnia Severity Index, we can see that over time, there is actually quite a stable outcome following CBTI. You get a good level of outcome or reduction, as we can see here. You've got 18.3 at baseline, 10.1 at post-treatment. It goes down at follow-up to 1 year, which is 9.2. And then over 10 years, you see quite a strong stability around ISI. So it does have that longevity. The other finding from this study was that treatment remission remained stable at 1 year. It was a 64% treatment remission rate. And at 10 years, it was actually at 66%. What this is suggesting to us and gives us data in the longer term is that not only CBTI works in the context of a lot of people, 70% or more, but it also has durability. And one of the elements behind this that the authors talked about is that the process of CBTI is really giving the patient themselves the tools for self-management. So, I mean, we could stop there and talk about, well, we've done CBTI, we know it works, we know it's effective in the majority of cases, and of course, it's durable. So we've beaten the beast of insomnia. Not quite. There are still a couple of problems that we do have with CBTI. There are still very few trained clinicians, and that does cause us some problems. It's prone to quite high levels of attrition and non-adherence. It's perceived as quite time and labor intensive by our patients. We do get a therapeutic response, 70 to 80%, but when we start to look at actual remission rates, they are 50 to 60%. And we do have to be mindful about acceptability across people, places, and spaces. And one of those challenges is when we've introduced digital CBTI. Let's address some of these issues in what's been done in the last year about this. Well, we know for a while now that we've actually tried to encounter that problem of few trained clinicians by introducing group therapy, introducing digitization of CBTI. One of the challenges with that is that it doesn't seem to be as effective for all people. The other thing that we should be mindful of is that when we start to talk about digital CBTI, for example, not all digital CBTIs are the same. And so we have to be mindful when all the data is aggregated in that way. But there have been some approaches in order to help people tackle insomnia on a much more wider dissemination scale. One of the challenges I think that we've got here, though, is that when is somebody going to get this? How do they know? How does the healthcare provider know that the person should be going to a group therapy or should be going to a computerized CBTI? So this is the latest work by Dan Taylor's group. And in essence, what they've done is they've created a web-based provider training platform. In other words, anyone can join into it and they can learn about CBTI and its processes, which of course is going to help with that referral process as well as giving people upskills around CBTI in general. So what have they got? It's called cbtiweb.org. What is it? It's about 6 to 10 completion modules. It was iteratively beta tested. And so, in essence, it goes through a process of each of the modules that we would tend to see within CBTI. What did they find from the introduction of CBTI Web? Actually, 23% increase in knowledge, and that actually went up to 92%. So great in terms of what it's intended to do was increase health literacy around CBTI. There were no differences between in-person and web training, which is great, which suggests that the web training doesn't lose any efficacy against a face-to-face training program. Uptake wasn't brilliant. The uptake generally was about a quarter after about 3 months of those people who were invited to take part in the CBTI web. What we did find that those were younger therapists, so younger clinicians, younger therapists, younger people in primary care. What's the outcome of this? Web training is a viable and engaging option to increase the number of therapists trained in basic CBTI, whether they choose to engage with the CBTI on a one-to-one basis or indeed have enough knowledge now to be able to talk about it in terms of its digital formats. What's the next other biggest solution? Well, one of the things that we've talked about is adherence to CBTI. There is a big challenge here. We talk about quite high levels, up to 50% adherence levels, non-adherence levels. And of course, one of the challenges is how do we actually measure that? And this is a really nice clinical review by the Monash group in Australia. And what they've done in this instance is they wanted to examine differences in how adherence is assessed, including by its delivery mode. Is that different based upon digital therapy versus therapist-delivered modality? They also wanted to identify the factors that predicted levels of adherence to CBTI. But I think one of the most interesting and important things is what is the actual relationship between adherence and treatment outcomes? And so that gives us a really interesting dynamic of trying to understand our CBTI. They did a systematic literature review of 8 different databases, and they actually had quite a healthy number of studies in the final mix. 101 studies were included in the final review. What did they find? In the majority of cases, it's a multi-item or single-item report. Did you adhere to this particular regime? Did you adhere to sleep restriction, cognitive therapies? And so in the face-to-face domain, what you found was that there were usually item reports that were included or embedded in the therapy itself. In terms of the digital side of things, it was generally put down to, was the module completed, time spent on the recommendations, and multi-item reports. So there are very different ways of trying to gauge levels of adherence based upon the modality. What components are most often assessed? And I think anyone who knows their CBTI probably has a good indication of this already. What comes out at top? Sleep restriction therapy. The reason that sleep restriction therapy is going to come out on top in both therapist and digital is because it's probably the easiest to track, because you're generally prescribing times to bed, prescribing times out of bed. And so it's quite easy to measure what that difference between what the patient actually does and what you've actually asked them to do. So adherence is much easier in the context of sleep restriction therapy. Outside of that, under the therapist framework, it's stimulus control therapy and then sleep hygiene recommendations. Conversely, it's the opposite in terms of digital. Sleep hygiene recommendations could easily be assessed within the context of digital, whereas less so for our stimulus control therapy. What influences levels of adherence? Interestingly, and I've actually seen this in clinic myself, a better sleep the night before the session. When I have a patient who comes in and they talk about, oh, I had a really good night last night, I'm very happy because I know that that actually does increase their adherence. And that's what they've demonstrated from this review. Fewer dysfunctional beliefs around sleep tends to impact on adherence. And I think that makes sense because in many instances, we're trying to identify and challenge those dysfunctional beliefs. Greater social support, again, we're feeding back into, you can see there's a theme that has been over the last year around incorporating social factors, partners, family members. And finally, the other influencer on levels of adherence to CBTI is levels of self-efficacy. Again, you can see that parallel between CPAP adherence and, of course, CBTI adherence. What doesn't tend to consistently influence adherence? Demographic factors don't tend to consistently identify who is and who is not going to adhere to CBTI. Comorbidities. This is an unusual one because we have seen in the past individual studies have identified specific comorbidities which may be a barrier to adherence. However, when looked across the whole range, it didn't appear to consistently influence adherence. So it's always worth trying to find the literature around which particular conditions and speak to those conditions where it does tend to relate to adherence. Psychological health doesn't appear to consistently influence levels of adherence. Depression does to a certain degree when we start to look at it on a broad range of symptom profiles, but overall, psychological health doesn't tend to, and not symptom severity either. So, however severe the symptoms of insomnia doesn't tend to also consistently influence our levels of adherence. What does this suggest to us as specialists? Well, I think one of the main recommendations from the review was that we need to determine and standardize what we mean. And we need to move it beyond just the quantification of time in bed versus prescribed time in bed, or time out of bed versus prescribed time out of bed. The other main finding really feeds into that there's less checks and balances around adherence in our digital CBTI. And so it's something to be mindful of when we are creating the next generation of digital CBTIs. How are we going to address that level of adherence? Or indeed, if you choose a hybrid model, it's something to be mindful of, that there are less checks and balances. Therefore, we can actually add more into the therapeutic context. How are we dealing with the time and labor intensive issue around CBTI? Again, this speaks largely to what we've spoken about earlier in terms of the different modalities that we have. Remember, we talked about group versus individual versus online. This is a really nice study, and it's a comparative efficacy and acceptability of CBTI based upon the mode in which it is given. So it's a really nice systematic review and a meta-analysis. What were they doing in this instance? Essentially, they wanted to identify which different delivery formats are best compared to waitlist controls in terms of the outcomes that we would see from CBTI. And they also wanted to look at the strength of the evidence. Remember, I talked about that CBTI, especially in a digital context, it's not always the same. There are different programs which do things slightly differently. And so they were trying to be mindful of that when they were doing the review and the meta-analysis. So they searched through 5 databases. They included 61 papers in the final review. Now, I know this is a bit busy. Don't worry. What we really need to focus on here is the green. And so the deeper the green, that's amongst the most effective. So what we've got across the top here is our indices of insomnia change. So sleep efficiency, sleep onset latency, how long it's taking somebody to get off to sleep, wake after sleep onset, how much time they're awake during the night, total sleep time, and then of course we've got our insomnia severity using the ISI predominantly. What we can see is on the other side here is you've got the different modalities as they have been arranged. Doing it individually, face-to-face, by group, guided self-help, digital, telephone, or unguided self-help. What we can see is quite a large spread around the different modalities and what they're affording, but really want to highlight the insomnia severity indices. And the reason that I want to do that is because there is very good evidence now that one of the main factors is daytime dysfunction. The main outcome that is meaningful for patients is how they perform during the day. It's less so about how they sleep at night. And so, although it's an important factor, insomnia severity, which does measure both daytime and nighttime impact, probably is a really good indicator of what's most meaningful to our patient groups. In this context, individual face-to-face therapy does have the best efficacy. So if we're looking to tailor our intervention towards reducing daytime and nighttime dysfunction, this is the best method to use, individual. You can see that a guided self-help also tends to have a good impact, but again, not as much in terms of the overall effect as we're getting from our individual face-to-face therapy. In terms of the other sleep elements, what you can see is that group therapy does tend to have a longer efficacy beyond post-intervention into the short term for sleep efficiency, sleep onset latency, and indeed wake after sleep onset. So our three main dimensions of nighttime problems really do respond most appropriately in a group context. Other areas, when we're starting to look at increasing total sleep time, we can see that digital assisted does have good short-term outcomes, and telephone tends to help an awful lot with sleep efficiency in post-intervention terms. We can see on the converse side that pink and red is where there are issues around the problems of sleep. And so what we can see is telephone is not very good in terms of post-intervention, and where unguided self-help is not good within a short-term context. So what's the main findings? From an individual level, the insomnia severity index at both post-test and short-term follow-up. Group, sleep efficiency, sleep latency, and wake after sleep onset. In a digital context, sleep time overall, as well as short-term follow-ups, and telephone, sleep efficiency at post-test. Least effective, telephone for total sleep time, unguided self-help for sleep latency at short-term follow-up. So what does that actually mean to us in terms of our therapeutic approaches? There is the potential avenue here for targeting delivery modality. So if we want to determine somebody's needs, what's the most important thing to them? And then we could actually pathway them to the different types of therapeutics. The other thing that comes from the review really is a need for standardization, at least in reporting our standards of care. So one of the things that they found was that people, when they publish the research, they're not always very clear about what elements of different therapeutics, modalities were included in terms of the modules. Finally, we can talk about going beyond insomnia in terms of CBTI. And this is some new research that's looking at, can we use CBTI in the context of other illnesses, diseases, and disorders? This is some nice work by Chris Drake and Philip Chang. And what they've done in this instance is they wanted to determine, does CBTI have an independent impact on suicide ideation beyond managing insomnia? So in this instance, what they had is 658 adults with insomnia. 19% of them had suicidal ideation on top of that. They treated them with CBTI, and what they wanted to see is there the indirect effect of treating the insomnia impacts on the suicide ideation, or is there a direct effect as well, whereby using CBTI impacts directly on suicide ideation? What they found was it was about 50% of the variance in terms of CBTI was through insomnia remission. So a large indirect effect, but that doesn't discount that there is also the direct and indirect effects. What they did find, which I think is really interesting, is that there were indirect effects on prevention of new onset suicide ideation. So CBTI appears to offer a buffering against poorer mental health in the future. And that makes sense because we understand of the very intimate relationship between insomnia and mental health. So we could use it in a prophylactic way to try to help people manage mental health in the future. Well, I don't do all of this on my own. I have a great team at Northumbria in England and also work with lots and lots of people around the world. Thank you very much for listening and have a great day.
I would like to thank Prof. Jason Ellis for the wonderful talk. Thank you very much for that exciting and it had a lot of information for us. The podium is open. If anybody has any questions, we can take 1 or 2 questions, please.
Sir, in the pharmacological management of insomnia, especially the sleep onset and sleep maintenance insomnia, so how do you choose between melatonin, non-benzodiazepine, sedatives, and benzodiazepine sedatives?
I would actually choose cognitive behavioral therapy for insomnia if it's available, because what we've seen is that although there's comparative efficacy between our BZRAs and CBTI, we know from the talk that CBTI lasts a lot longer. I would tend to not, and because I'm in the UK, we don't tend to prescribe melatonin very much anyway, but we've also got to think about the mechanisms of action. Melatonin really is more of a drug to help manage the circadian system as opposed to the sleep drive. And so if the problem is a sleep onset difficulty, then perhaps melatonin will be efficacious in that context. But that's if there is a significant circadian delay. In terms of maintenance, again, that may be more challenging if melatonin works as the offset period of sleep. But I would always go back to CBTI because it's non-pharmacological and certainly a lot more valid in terms of its longevity.
Thank you, sir.
There's another question for you.
Hello, I'm Dr. Desha. So we came across a recent patient she's a young girl who has insomnia, but the thing, her sleep hygiene has a lot of issues. So she goes to the bed with her phone, and without her phone, she does not fall asleep. So that's her basic problem. So we don't have CBT in Sri Lanka as such. So what kind of advice would you just focus on when we are treating this patient, or what would you advise for this patient actually?
It's a great question, and I think one of the things about dealing with younger people, for example, is that we have to be realistic. If we're not going to ask the patient here to remove their phone, that's going to be difficult, as we can see. What I would tend to do in that instance is I would actually do it in 2 stages. I'm not as worried about people using phones at night. I'm actually more concerned about what they use them for. If they use them for passive activities, like perhaps watching a movie or reading, that's not as detrimental as social engagement. And it's the social engagement that adds an extra layer in terms of that cortical arousal at night. So what I might do is actually talk to the patient about setting a time limit on when they can do specific activities with their phone. Number one, you can use your phone in the bedroom, but it's only got to be used for passive activities such as watching, and setting a time that that is to go off. Prior to that, they can use the phone for social engagement. I don't know what young people are using these days, but it could be Facebook or Instagram or TikTok. Keeping that separation between the social engagement and the passive engagement will be a much helpful strategy. The other thing I always talk about is I'm never going to ask someone to remove the phone from their bedroom. What I would ask them to do is at some particular point and set a time to actually put the phone on charge. And this is an opportunity for them on the other side of the room to have the phone charging rather than them engaging with it. But yeah, we have to be realistic. It would be lovely to say, everyone remove everything electronic from the bedroom. In the real world, that's not going to actually happen. So let's set limits around that usage instead.
Thank you very much.
On behalf of Sri Lanka College of Pulmonologists, I would like to thank Prof. Jason Ellis for his time with us. Thank you very much.
Thank you.